and welcome back to the How I Rehab podcast. My name is Nick Kane. Very excited today to welcome Fearghal Kerin onto the podcast to chat around the recurring hamstring, mainly around T-Junction management and some intramuscular tendon hamstring injuries. We did have Fearghal on the podcast some time ago talking to T-Junctions, and part of what we'll do today is try to develop his management process from that podcast and how it might have evolved over the last 3 to 4 years. Fearghal, for those who don't know, had a really good stint at Leinster Rugby for 9 years before transitioning to working at Chelsea Football Club. The last couple of years before recently starting Kerin Performance, his consultant business. He holds a degree in physiotherapy, a master's in sports injury and rehab, as well as a PhD from the University College Dublin on his research focused around hamstring injuries in professional rugby. Very knowledgeable in the space. So please enjoy this one. Reference back to our old podcast if you need. And also you can touch base with our last podcast episode, which was the clinical cases chat with Joss and I, sort of breaking down some of Fearghal's work. So I might add a little bit of a layer to hearing from the horse's mouth today. Now, considering we are talking all things hamstring, it'd be remiss of me not to mention our new event that is happening in northern Italy at the Australian Institute of Sport facility. The end of June. It's a day and a half. It's going to be really practical and hands-on. Fearghal's presenting there, along with Chris Brahma, Andrea Lupi from Real Madrid, and Michael Giacomis and Ben McDonald, both from British Athletics history and current English Premier League clubs. So we've got a fantastic lineup. It's going to be really interactive. The bonus content that comes with that is fantastic, and it's online content from Craig Purdom, Scott Hume, Steph Lazarchuk, which is all around aponeurotics and difficult hamstrings. So it's a super, super comprehensive resource if you can get yourself to Italy. It's going to be super fun and a great venue. So really excited about that one. Masterclass-wise, Brian Heiderscheid's masterclass literally has just dropped on the platform. A really great take through hamstring rehab and some things that you might not be doing that you should be probably reviewing in the rehab, from looking beyond just strength numbers on your Nord board work, how to optimize some of the training through outer range eccentric strength, and looking a bit deeper than strength alone, and whether or not there's some compensatory strategies there across the hamstring muscle group is just a couple of the little clinical takeaways in there that I'd definitely recommend getting a good look at that. We have masterclasses later in the year coming from Nick Court, who's working the EPL, and Fearghal himself. So lots of hamstring content coming your way. But yeah, please enjoy this chat with Fearghal. It's fast-paced, plenty of takeaways, and we'll get some nice, clear snippets from this podcast that you can sort of really, include in your hamstring management moving forward. All right, welcome, Fearghal, back to the How I Rehab podcast.
Yeah, thanks very much, Nick. Thanks for having me on again for round 2.
Mate, round 2, it's been a while since we had you on the first time around, and now you're a bit more of a common name around the place when it comes to hamstrings, and quite prominent there on social media around getting some really good information out for clinicians and running some courses. Give us a quick rundown on what you're doing, Kerin Performance, and how we can utilise your services, and also what you're doing since you left Chelsea around a year ago, I think.
Yeah, as well. I suppose actually very grateful to you, Nick, and to the podcast, because I actually think touching on T-Junctions on this podcast would probably be very big for me for building out my network, because as we've talked about before, there's not that much out there resource-wise. So I think when you look up T-Junctions, one of the first things that comes up is some of the things that we put out together. And that was really helpful for me building out my network and ultimately getting the opportunity at Chelsea. And then, I decided last summer that it was time to go out and do my own thing. So I basically have a clinic in Dublin, I have a clinic in London, and then I do a lot of consultancy for different clubs basically around the world now. A lot of stuff from guys in Australia, in Central Europe, UK, and some American stuff too. So it's perfect, really. I get the nice mix of a la carte, but also over 90% of what I see is hamstring injuries. So I'm learning an awful lot more than I had learned at any period of my career so far, just from the volume that I've seen.
Yeah, I love that. We had you out in Australia recently, or SportsMap didn't, but the AFL Physio Association did, who we have a good association with. And you presented at the conference there alongside Dermot Simpson and Elzak, and obviously Purds and Shaki as well. So it was a quality conference that's put on for the AFL physios, which is our mainstream football competition here in Australia. But it's good to catch you. Had you out to my footy club for a little in-service as well, which was lovely. Mate, but as you mentioned there, we're going to be pretty sharp today in this podcast. We're going to touch on a little bit around maybe what's changed in your management from T-Junction space since last time we discussed, and sort of delve a little bit deeper into some of your, you're seeing a lot of recurrent hamstrings, so we'll chat through some of that. And, I was listening to your podcast the other day on FMPA from the Medical Society crew there, and it was a great take. So those that want to get maybe a rounded reference from extra info from yourself, I'd recommend listening to that. I'll try to break a couple of things down further. Mate, but to kick us off, first question, I guess, can you give me your 3 big key points when it comes to addressing recurrent hamstring injuries?
Yeah, so I suppose what I always say is coming out of sport and moving into a space where I only see primarily one type of injury, you learn so much more. And I was actually having this conversation with Pards a couple of days ago where I think I see the same thing over and over again. He says he thinks actually the variety in what you see in the challenge and hamstring is what he finds fascinating. But I must say I tend to come out with some of the same principles again and again, either on the hamstring that's recurrent or on the big hamstring that I'm trying to stop becoming recurrent. So I think, like I'll always say, my big two is to get my anatomical diagnosis, get my functional diagnosis right. Anatomical diagnosis really is what's my location and my severity, and I think that's critical for everything that's to come. I have to say, a lot of the challenging hamstrings that I see are ones which haven't necessarily got that diagnosis right in the first instance. Be that because there's been some confusion over whether it's free tendon, conjoint tendon, intramuscular conjoint tendon, intramuscular tendon, or aponeurosis, as you guys would say down there, or whether it's a peripheral A or B style injury. And then the whole confusion over the T-junction and the challenges down there, which I'm sure we're going to get into. So I think the location piece is just critical, and the severity obviously as well. Then the second, I suppose, sub-classification of that is the functional side, and then I kind of work into, well, the hamstring itself. So what is it that we're going to work on specifically to the hamstring? Is there something that's some stone that's been left unturned around the hamstring? I do then start to ask the question, okay, primary things we're looking at here is, are they strong? Can we think around things around force transmission? Anything around the architecture? And then is there something specifically around activation or where they're actually finding they're doing the work? They're the main questions I'll tend to ask around the hamstring specifically. And then I suppose the third thing is around then the system in general. So particularly when you're dealing with the second, third, or fourth opinion or the recurrent hamstring, the question really is then, well, why has it happened? Particularly when most of the people that are going to come to you have already worked through RDL, Nordics, bridges, etc. So most people have done that side of it. And for most people, the hamstring is probably marginal gains at that point. Actually, where we can look to make a huge difference is pick apart their previous injury history and pick apart actually is there something else within their system that's overstressing the hamstring on a single step or on every single step, and whether that comes from the knee, the ankle, the hip, the low back, or whatever it is we can test. And then for me, I suppose I bring those three things together, the anatomical diagnosis and the two aspects of the functional diagnosis, specific to the hamstring, specific to the system. And then what I try to do in recurrence rehab is to craft a narrative. So basically, if you came to me, Nick, and asked an opinion on an athlete with a recurrent hamstring, I wouldn't be able to necessarily promise you I knew exactly why it happened, but I would try to use that process I've just described and then tell you a story of it, and then tell you a story where I could go, well, actually, maybe we had an underclassified T-junction at this point here where he felt a pop, but there was a big game when he returned in 3 weeks, and he's had a sense of tightness since. Maybe that ankle injury he had 18 months ago where his actually knee to wall is down 3 centimeters, maybe that's now influenced what he looks like on swing phase on the left side. Maybe that back pain that he has after every long trip, maybe that's something that we've just accepted as being normal, and so on and so on. So basically trying to pick it apart using a process pretty similar to that. And then, I've not even really touched on the hamstring in that answer.
Yeah, well, you have, because obviously you've, certainly the anatomical diagnosis and the force transmission architecture and the activation piece, and then obviously you mentioned more through the system, the rest of the body. I think for today's chat, we'll try to focus around that hamstring components, and I guess sticking to first point at the moment, anatomical diagnosis. I'm going to reference here back onto the T-junction space that we have talked around. you know, are all T-junctions created equal? First and foremost from a question. And I relate there to, at the moment you hear about it a lot, but it's like, oh, that's a T-junction, so that's bad. Do you think there's an element of sub-classification in there that maybe we don't know about or that we're working on or that some people do know about? Like yourself, saying this one's actually pretty bad and it's going to be like ABC, or this one's not as bad and it is maybe, a 4 or 5 week injury and you slightly change your management.
Yeah, great question. I would say absolutely they're not all the same. So if we go back to Tom Entwistle's work, he had 70% or so recurrence rate, but actually that means 30% of them didn't recur. And then you'd like to think with the evolution of how we manage these, their recurrence rate should be dropping and dropping from that 70%. But in and of itself, some recur and some don't. So there has to be answers to get from the ones that don't recur. I don't think we're there in terms of answering that question well. I think that there's lots of data sources, none bigger than the AFL, but also the UEFA Elite Injury Club study, Elite Club Injury Study, where we could start to pick out, well, which are the ones that do break down and which are the ones that don't. So without having those data, we can only speculate and try and pick things together. Now, I took an interest in this 7, 8 years ago now, and I started to put together my PhD process on this. And I did think at the time, but by the time we publish this, everybody's going to be published on T-junctions, because for the likes of ourselves who work with athletes, it's so topical and such an important area for us. But actually, there has been a real dearth of new literature out there. So what you can kind of do is start to pick out small things from different studies or from expert opinions and try to link those together. So I suppose some of the key things are, a lot of what I see are guys and girls who come with, primarily males really, who come with, okay, I'm getting recurrent A-type injuries. I think a guy spoke on a webinar for the FA medical side a few months ago, and the radiologists were there, the guys who wrote the BAMIC, who we're very experienced in this area, and they would say they don't believe there's any A's and B's in this particular area. So effectively, the tissue should just be classified as C. I think that makes sense too. If we do think it's an area of high recurrence, it makes sense to give it a slightly higher classification, or certainly not to go in the A or B. I almost think for me, once it's a T, I don't really care whether it's A, B, or C. I just know it's a T. So I think getting away from the A's and B's is probably helpful there. Second thing is the concept of superficial versus deep. So again, if you look at some of what Carlos Pedret has published, and certainly what he has spoken about, is the idea of the deep T-junction being a less severe injury and maybe being one that could return in 3 to 4 weeks. He specifically has that line in one of his papers. I have to say I'm not fully there in terms of that. I put out a tweet about a T-junction thing a couple of weeks ago, and I got 2 replies to it saying, well, we know that superficial injuries are the more severe type. I'm not sure. I'm not saying that they are or they aren't. I'm just saying I'm not sure. I'm not sure I've seen the volume of deeps that have returned without a problem that I could say, well, actually, these are the ones we can push. I would say in my experience, there tends not to be a major difference, but that may simply be a lack of numbers, or the fact that I'm not a sonographer, perhaps. But I don't know we can make that sub-classification, but certainly that is an opinion that's out there, is that superficial is a more severe injury. Beyond that, then I think, well, one starting point is, we know for the BAMIC classification, if an injury is a C, it's not a 1. The starting point for a C-type injury is a 2. So all of a sudden, you're almost starting your T-junctions on 2C if we apply that classification system. I think the real challenge with these is that we know that they tend to be undercalled on MRI. I think having a small grade T-junction doesn't guarantee us a good outcome. Having an athlete that presents very well on our testing, admittedly with the limitations of our testing, which is, for the most part, our testing is, Askling, M-Fake, Bridge, Curl, very, very linear style testing. And actually that probably doesn't have enough shear to actually properly strain the T-junction. So there's real challenges there in figuring out, if all T-junctions aren't created equally, which are the ones that we can push and can't push. And I guess the last point I'll touch on this is, if you actually look in Faris Haddad's surgical case series, Koyani and Haddad, they touch on the fact that actually for a third of the cases they carried out surgical repair on, they had been undercalled on MRI, or not so much undercalled on MRI, but didn't look as severe on MRI. So there seems to be an element for this type of injury that they can look intact, or certainly look less severe on imaging than they may actually prove to be in surgery. And I think probably a combination of clinical experience, history taking, ultrasound plus MRI probably comes together to help us try and make better decisions on which are the ones we can push and can't. But I think it's a really important question that came up at the AFL conference a couple of times of all I want to know are which are the ones I can push and which are the ones I can't. But I think it would be crazy for me to say we can definitely push the deep because I just don't think we're there.
Yeah. While we're on, one of the questions I had planned was what sort of changes in your management across this period, and we're sort of covering off through that as we go. But the ultrasound that you mentioned, I know there was a paper, and Joss and I talked around it in our recent clinical chats podcast. It was just come out a week before this one, but referencing your paper, and PERDS has always been one for. They're looking at the ultrasound from an element of tissue healing, and obviously you do as well, and you've got good access to a radiologist to do that. How does that guide your early loading, and how does that guide your readiness to sort of reload on the field as well? So early loading by gym-based loading and into the field from there.
Yeah, so I think it's the first question is what are we asking our radiologist or radiographer when we carry that out? And I've been lucky, I've worked with Kevin Cronin, who's a radiographer here who works a lot in hamstring injuries, and obviously radiologist in the UK as well. So I suppose one of the first questions that's asked is can sometimes be used as a deal breaker on some of the surgical versus non-surgical cases. Actually, are we seeing a gap? I suppose what the benefit of the dynamic ultrasound is that we can actually things can look much worse when we put on a prone curl and isometric contraction. We published on this in the BJSM sports medicine images section. But effectively what may look like opposition between the short and long head can then turn into a gap when we put on that curl. So we're then looking at actually, do we see synchronous movement? Do we see a gap? And do we see a hematoma? And then the question becomes, okay, well, what are we doing about those three things and what matters? So for the hematoma, I suppose it gives us the question of, well, one, are we going to do something about that, or are we going to aspirate it? And I'm not saying that we do or don't have to, but what we can do is certainly track that on a week-to-week basis. That should be getting smaller. Similarly, that gap should be getting smaller. So my question will be, if we check it on a week-to-week basis and it is not improving, then we need to reconsider again. So what questions is that asking of us? Well, one, is my loading appropriate? I may not be at the most appropriate style of loading, whether that is actually just around something like exercise selection. Maybe I'm loading, outer range knee curls, something like that. Maybe that's not appropriate because we see gapping on an isometric prone curl at mid-range. Or maybe it's that my frequency is incorrect, or maybe it's actually that this needs a accelerator, something like PRP. We could consider it wouldn't be a first step for me, but it might be something actually we're at 3-4 weeks and we're not seeing a change. Or maybe that hematoma is influencing the opposition and the closing of that gap, and so on and so on. So I would consider that to be an important, particularly say the gap, for instance, and the synchronous movement. I would consider that to be a return to run marker. I wouldn't run somebody at, let's say, 60 to 70% while we've seen a gap on dynamic ultrasound. Similarly, I wouldn't load somebody who has a gap at, let's say, a 30-degree prone curl on ultrasound. I wouldn't load them in outer range. So let's say length and state eccentric training, so hip flexion, outer range, knee extension. I don't think that necessarily makes sense to me. I think it makes sense to flirt on the edge of what's appropriate and promote mechanotherapy that way and get the maximal adaptation that's going to help us when we do go back to the field. But I don't think it makes sense to jump off the cliff on that one.
Just talked our way through the ultrasound. Just to be clear, we're doing a dynamic ultrasound, and you're sort of doing that generally have them doing like an isometric contraction in a prone setup. So the radiographer will be getting that athlete to resist into a movable hand or force, and he'll have a look at different angles. That's sort of how they're doing it, just for our listeners at home to be able to visualize that.
Yeah, definitely. And I think there's going to be more levels to this, because I think the more, let's say, if the more load we put on, potentially the bigger gap we'll see. That would make sense. The more rotational bias, potentially, the more gap we could see. And I've spoken to PERDS who has, certainly at the time, probably 18 months since we had this conversation, saying that he had a look on it on some rotational movements and hadn't seen it promote the gap. But again, there might be somewhere to go on that and going, okay, so we now see I'm going to make this up, but at a 30-degree knee flexion angle, we don't see that gap when we see synchronous movement. But actually at 15 degrees, we do, or at 15 degrees against X weight, we do, or at 15 degrees with rotational torque against the outside of the heel, we do, or we don't. So I think, we can be overly binary in terms of we do or we don't, but actually what's the task we do? Again, those answers aren't there. And I think that's for the radiographers and ourselves and those that are in those clinics, I think, to kind of play around and ask those questions. There's a huge appetite for those answers. But I suppose specifically if I say, and in the paper that we published on this approach, that's how we did it. We did a light isometric contraction in kind of mid to outer range.
Yeah, okay. So it sounds like there'd be certainly avenues still to explore down that route. And I guess you're talking, when you're talking there around, maybe further outer range, the rotation component, coming back to, I guess, more of a clinical standpoint, and you touched on some tests earlier, max hip flexion, active knee extension, isometric prone testing, things we do in the hamstring rehab as a clearing test, so to speak. What do you use later in that rehab phase? So I'm talking as you're working your way down, you want to know it's going to be able to tolerate certain loads and certain conditions on field before you ramp them up. Do you have a couple that you think give you more confidence in biasing that tissue?
Yeah, so I was running a course with Alan Murdoch a couple of weeks ago back here in Ireland, and that was effectively one of the questions we got. And I gave an answer to it, which was probably a little bit wishy-washy, which was, well, our tests are very linear. It's very difficult to have confidence. Imaging can help, but I think it only helps to a point, and so on and so on. A lot of what we've spoken about already, and didn't really give a strong answer, which I think probably represents my lack of utter confidence that we have the right answers here. But then Alan took the mic and gave what I thought was an exceptional answer and effective. And now it's something that the two of us are working on effectively as a curriculum to actually go, okay, so if we think that our tests are too linear, then how do we bridge that gap? So what do we think? What's the mechanism? What do we think is high load for that? So we think the mechanism in high load is trunk rotation, deceleration, trunk flexion, hip flexion, knee extension, that kind of position. So let's work back from there and take the best of those of that pattern. So how does rotation influence our rehab? And then effectively just set up a curriculum then of exercises. So be that, okay, let's just say, for instance, we're starting off on our box to box bridge, Alex Natera style, but actually we might then introduce a Palloff style hold as part of that. We might then add an aqua bag where they're doing like kind of wipers with an aqua bag, and then we progress to throwing a ball at them and getting them kind of resisting rotation. So effectively there is a curriculum of exercises going from linear to isometric rotation to controlled rotation to uncontrolled rotation. And that may give us some more confidence. Now, the challenge with these injuries is they'll always tell you they're fine. They are always symptom free until they're not. But I think whether that approach allows us to they might come up with symptoms, go, actually, do you know what, I'm feeling that in the area, and that might tell us something, or whether it helps them train themselves not to go into that position. So we're actually, effectively doing constraint-based training that they can control their trunk and don't over-rotate. Or thirdly, whether the approach, promotes healing and actually promotes their remodels them in a way that allows them to actually control that region better when they're in that position. Whatever it is that they do, I think working through a clever curriculum of movement is really helpful here. And then we can just apply that to effectively anything. So I've talked there about an isometric continuum, but then we can also take that into our let's say our outdoor style work. So whether that's like as simple as, okay, so we're doing our scissors, but actually are we doing that with some kind of trunk rotation? And again, we can create some kind of model from A to Z. So again, I'm stealing that answer from Alan and implementing some of my own thoughts on it. And it's something the two of us are working together on a project at the moment. But I think that is effectively how we do it. If we think the answer is it's too linear, then we just bridge A to Z, fill in some gaps in between, and hope that the athlete gives us the answers. And along the way, we might train them and make them more robust too.
Nice. Okay. Sounds like an interesting, like a great approach, and obviously, yeah, looked like a great course that you and Alan ran over there in Ireland. So something to keep an eye out for those keen to sort of touch base with these two on the topics. I'm going to throw you one last T-Junction question before I sort of throw a few punchy ones at you for more around overall hamstring management. But I know you're working with one of the surgeons, Faris Haddad, or seeing a number of his patients post hamstring surgery. I guess we're dealing with these athletes and people we do see, and we talk around surgery at times. Where does that play a role for us? Clearly, if you've had recurrent issues, it's probably something that's on the table. But is there a way we can determine which ones maybe are better suited to go down that pathway and which ones are not?
Yeah, so I suppose that you've answered the primary answer on this is recurrence. So if they've already rehabbed well, then I think it doesn't necessarily make sense. So again, if you've had an athlete, you've rehabbed them really, really well, and he's had a 4C, and then they turn up and then he re-injures with a 4C, let's say, and then turns back up at my door looking to go again. My question is, well, is there something obvious that I can improve on from what Nick has done there? So, if they've not loaded appropriately, if they've got their timeline wrong, so on and so on, then okay, maybe that makes sense to go again for a second bite at it. But in general, the biggest indicator for me is if they've had a high grade injury, they've rehabbed it well in an appropriate timeline, and now we're back, unfortunately, in the same situation, then I mean, it could obviously make sense that those would clearly be, in my opinion, a surgical candidate.
Yep.
Then there's, I suppose, we're thinking proximal and distal injuries. We obviously have subclassifications then too, like our avulsion style injuries, our semitendinosus ruptures and avulsions, which my experience don't tend to do as well. But the specifically, if we go to the T-junction injury, if you actually look at what's published on them, they're only talk about 3Bs and 3Cs. So again, it's just really interestingly, they don't describe any 4Cs, which again, I think tells us how many of these tend to be undercalled through imaging. I think if we're effectively looking for the athlete's individual demands, that will influence it too. So I think there's a big difference. Like I wouldn't get my T-junction repaired tomorrow, but maybe if I was a rapid wing back in soccer, maybe I would consider it. I think if we have a palpable defect, and we do see it sometimes, I think the ones that really concern me or that I'm a little bit wary of are the ones where we try to get them to contract Bicep Femoris Long, or we try to get them to contract their hamstring, and you see that they really struggle to get activation of long head. It's one of the first things I look for. And I think on the challenging T-junctions and the T-junctions that don't do well or haven't done well, it's probably the primary thing I observe. And that concerns me. And I think they're the ones that I actually find it really hard to get them working well through their lateral hamstring. And so that would be part of it too. I think, I suppose, juxtaposing that with MRI signs, probably with a follow-up dynamic ultrasound, and then we start to figure things out maybe a little bit through that. Again, I mean, if we look at the London consensus, there is no this is a surgical hamstring versus that's not a surgical hamstring. I suppose specific to the T-junction, I think it seems to be a more straightforward surgical process than the proximal hamstring. Time to return, they describe it as 11.8 weeks plus or minus 3. So actually 8 to 14 weeks. You guys down there are probably the ones bringing them back in 8. But the timelines can be reasonably aggressive, and they seem to do very, very well. I'll often say to people, I'm more comfortable rehabbing the post-op T-junction than I am rehabbing the high-grade recurrent T-junction. Like, it's just an easier rehab. I think that flips a little bit in the proximal hamstring. I think it's a more challenging surgery. I think that's not for debate. The timeline's a little bit longer. And actually, I have to say, I'm very comfortable to rehab the proximal 4C long head style injury. If you give me enough time and you give me the commitment and we go through the process, do really, really well, have sports medicine input and all those things, I think actually, I don't know, 19 times out of 20, 9 times out of 10, whatever it will be, you do very, very well on those big 4C style injuries non-operatively.
Lovely. Good answer. I'm going to come through with just two follow-up questions on that. When you talked around, so I sort of got the surgical timeline from you there around both what's in the literature, and you mentioned maybe a little bit faster here in AFL. I think 8 weeks should be maximum. The timeline when you said recurrence and reasonable timeline with good rehab. What's a reasonable timeline now? And I guess this comes from where you were maybe 5 years ago, and obviously in our clinical chats podcast last week we referenced a sort of article that you wrote around a bit of a phase timeline, which is around 8 weeks, give or take. What's a reasonable, in quotation marks there, timeline for a T-junction nowadays?
Yes, my starting bid is about 8 weeks. So context is king. So basically, almost start off at 8, and then I plus or minus 1 or 2 here and there for sporting context. So if you come to me and you say, like, a really frequent thing I have at the moment, working with a lot of Irish guys, is they're coming to the end of the league, which is almost like the less important part of the season. And a lot of guys coming to me saying, if I don't get back for part of the league, I effectively may as well not be there for the summer for when things, the really important games. So they're going, I can't take 8 weeks on this. And that's absolutely fine. We just do it in a timeline that suits you. You understand that it's not the optimal timeline. And then our management of that becomes a little bit different. So whether that's 6, 8, 10, 12 doesn't really matter. It depends on when I ask you, what are you hoping for and what are your goals from the session? You give me that answer there, which might be, I never want to get injured again, which is okay. Well, actually, we need to take a little bit longer here, clearly, versus I want your help to come back in the shortest time possible, which is different again. Some of the things I do within that, I personally believe the most important thing with these is don't break down for as long as you can. Just get as far into the rehab process as you can without a re-injury. I think that's really, really helpful. So I generally say to most of them, if we can get you 6 weeks in here without you breaking down, I think we should do fairly well. Most of these break down in or around that kind of, and you look at Aston Villa have published a little bit on this, and they pointed how a lot of these injuries that happened for them broke down within rehab. So if we can get them to the end of rehab without breaking down, I do think most are okay. Okay, you'll have 1 or 2 breakdown first game back, that kind of stuff. But or third game back, but really for the most part, if you can get them through the early phase, I think you'll be okay. So then that becomes, okay, so what am I proposing? I'm proposing being some way cautious for 6 weeks. But when we hit that, let's say 6 week line in the sand that I'm just throwing out here, they should be very well prepared to change gear at that point. So, they should have adopted the positions and postures associated with high speed running. They should be sitting in around, let's say, the 80% mark, which we know is very, very, which we know probably there's an incremental load on the hamstring beyond that point. We should be lowering them very, very heavily in very appropriate ways with our best exercises. But in a way that probably means they don't re-injure. And that way, when we do get to a point where imaging, let's say, for instance, or just chronological time tells us our risk might be starting to go down here, then we can up them. Now, if you come to me and you say, I need to come back from this injury in a month, and that's fine too, because you actually look at what we published in my PhD, my understanding of the average time from the AFL as well is in or around the month for a typical T-Junction style injury. That's fine too. All I would just say is there's an asterisk beside you, in my opinion, for another month after your return. So that might have some influences on what we do. That might be you do more in terms of doing stuff indoors, or it might be you do less in terms of doing stuff indoors. It might be that actually you come back in and we don't give you as much speed exposure as we give the other guys. It might be that you only complete 80% of training volume. It might be that we don't do additional top-up conditioning. We're just effectively doing competency-based rehab and competency-based weeks. You can do any way you want. That's just thoughts that I have when somebody comes to me saying, I want to come back in a month. And I just go, right, fine. But we'll just have to modify some things because we know these probably are likely to break down for at least a couple of months. So there are some of the approaches I use. So the 8 weeks, I'll throw 8 weeks as a kind of trivial starting point in my head for what's a safe enough return for the vast majority of these. And then I work back and forth a week here, a week there. And then things change, obviously, on the recurrent one. If you want to never break down again, there's probably stuff to clean up along the way. You probably need to just get out of the fire for a little bit of time. And then I start drifting that 8. My starting bid probably becomes 12.
Yep. All right. Lovely, mate. Comprehensive as always. I'm going to sort of move away from T-Junction a little bit, but even though we're still going to be talking around hamstring, so certainly it will apply. We're going to be punchy for the last part. And obviously, sneaky plug in here as well. Obviously, we did a masterclass on T-Junction injuries with you that we filmed at Bath University, which is an amazing facility. So that's coming out later this year. So you get to see all the practical components of you assessing, taking through exercise stages throughout this. So I'll actually, apply perfectly. And that will, as I say, later in 2025. So stay tuned. Now, mate, on the podcast, or you've mentioned a little bit of social media, and also, in another podcast there that I referenced earlier, a bit around optimal healing. And you sort of referenced, the times that you have done some serial imaging at 2, 6, 12 weeks, and the ones that you got the loading right, you felt it showed better healing versus the ones that didn't. And in that, you're probably talking to, the frequency or, how well the athlete was loaded and whether that was you doing it or someone else you've seen. I guess moving from that, what does this optimal loading look like? And I guess, you know, if you're talking around loading for optimal healing, are you talking around, at what stages? Is it lower maximal voluntary contraction, isometric work to get good healing? Are you just going heavy and eccentric work to get that adaptation? Just to clarify a little bit, because I've heard you say it a couple of times, I'd love a little bit more detail on, what you mean by that optimal loading.
So I suppose it might be even easier to my starting point is what's suboptimal loading. So what I think is that the ones that I've loaded consistently well, I think those are the ones actually where we see that return of tension a little bit earlier than the ones where I've actually loaded them poorly. Be that I had gotten something wrong within rehab, be that the athlete's gotten sick and missed a couple of weeks where we've actually come under pressure for whatever reason and we've returned him to run that little bit earlier. And actually, he's at 90% speed and we're 3 weeks in and we scan him at 5 and he's still getting recurrent tightness and we still see lost tension, we still see lost edema, and so on and so forth. So I do really believe that we are the architects, or at least I like to believe we're the architects of actually what those 5 signs that Carlos Pedro talks about in his research of what we can look on an MRI and judge what healing at the given time is. Whether that's overly ambitious of me to think it, but that's how I kind of motivate myself through it. What does optimal loading look like? I suppose let's go back to Noel Pollock's work with the British Athletics Group. They have their 5 principles for rehab, but they effectively have a different approach for C-type injuries. Their approach for C-type injuries is they delay heavy eccentrics, they delay outer range loading, and they delay speed. So there's my starting principles. That doesn't mean we don't do those things. It just means we break those up a little bit. But like I mentioned on the T-Junction, there's different aspects of each of them. So I think isometrics are really, really important. So isometrics allow us to load at longer ranges than eccentrics do in the early phase. Isometrics probably give us an adaptation that's specific to tendon, if not the intramuscular tendon. Isometrics allow probably some of that stress shielding concept where actually we haven't talked on activation in too much detail yet, but where we can overcome that selective inhibition of biceps femoris long. That is probably helpful too, to stimulate healing. And then as we work our way into true range isotonic style loading, that's where my tempo loading comes in. So again, I just kind of refer back to, okay, what do we know about changing structure within tendon, Seth O'Neill, Krausgard approach, all these kind of things. They seem to like time under tension. They seem to like heavy, slow resistance, and they seem to like tempo. So I will do lots and lots of tempo style loading. So I had been at a 3-2-3 style loading, so 3-second concentric, 2-second iso, 3-second eccentric. And then the handbrake on this would be my diagnosis. So if it's a big C style injury, okay, we're not going to hold it true range, but I'll still do my tempo within what we have. And I'm probably now, if we look at where the most recent literature around what optimal loading for this looks like, it's probably lengthened state eccentric training. So lengthened state eccentric training from Mayo last year has been shown to get that 9% increase in intramuscular tendon size, which may well help with transmission of force. So again, that's probably where we're trying to build to in terms of what's going to influence healing and possibly or adaptation and possibly healing within the tendon. So within the confines of my diagnosis, I'm progressing. That's my endpoint. That's where I want to get to from a gym-based loading. And then I'm just working back off that. So maybe it's lighter load, moderate range, tempo-based loading. But that's how I do it. Starting from probably knee dominant for my proximal injuries, progressing my way to hip dominant. And I suppose the next thing that I would touch on is for most of these athletes, they find a way to bypass where you want the load to go. So really interesting thing that I see, literally one yesterday, and Anthony had lost a load of bulk on his long head, and you ask him, he's telling me about the exercises he's doing, and he goes, yeah, but all I feel there is I feel in the back of my knee on the inside. And I'm like, right, brilliant. So the exercises you're doing probably aren't the appropriate one, and they're probably not optimal loading. So I would say my primary principle is basically go get my diagnosis right, establish the other thing that's going on in the system, and get my isolated biceps contraction. Because there's no point in me doing all this beautiful tempo-based isometric loading and lovely exercises and swinging around med balls and aquabags and so on and so forth if we're not if that load and adaptation is not going through the muscle that I want them to go through. And I know there's a debate out there around, can we isolate proximal or distal? Is this exercise biasing that muscle versus that one? And all I would say to that is, not even from playing around with EMG, but actually having dialogue with the athletes on, what are we feeling? If they're telling you they're feeling on the back inside of their knee, that is probably not optimal loading for the biceps femoris long head proximal. Um,
Yeah.
so then we just change that exercise. And I probably think the cheat code for me is integrating rotation within rehab. So if we think, and when I say rotation, I really often mean just isometric anti-internal rotation. So we always think of the hamstring, it's the hip extensor, knee flexor, but kind of forget it's got that really important role as a lateral rotator. And when we're trying to upregulate biceps, I think just putting an isometric rotational component into it really, really helpful. So yeah, optimal loading, it's a case of respecting my diagnosis and allowing that to tell us, well, actually, what are the contraction types, what are loads, what are the ranges, and what are we trying to build towards? We're trying to build towards length and steady eccentric training. To me makes sense, because length and steady eccentric training will get us all the adaptations that we want. They'll get us stronger, they'll get us bigger in the muscle, they'll probably get us adaptations within the intramuscular tendon. They will probably change our architecture, because we know for a long time now that outer range, eccentric, heavy work is what influences fascial length. And that's probably an exercise that influences biceps femoris long head too. And if we underpin that with good coaching, good discussion, good cueing around what that actually should feel like, then I think we're on to a winner. All the while, we know what else is high end load for them: sprinting. Where are we in terms of steps on that then? So angular velocity is 1,000 degrees per second. Of course, we don't want to do that. So let's just work back. What are our positions around running mechanics, and then how do we build them really appropriately along that journey too?
Yep.
Yeah, that would be what that looks like in a quite a long answer.
Nice, mate. You actually sort of ran through with that. I should have gone with probably the question around activation first, which obviously you are speak to a bit, really big on long header biceps activation or reactivation. So if the injury and you lose that piece, then are we getting compensation through short head biceps or medial muscles? And that you've obviously spoken to Springbok a little bit around that imbalance a bit. What are you seeing in the space of either that sort of short to long head imbalance piece with, I guess it's coming back to some of the T-Junction injuries. What are you seeing here? Is that something that we maybe should be exploring? I know from experiential stuff that played around with, you're seeing in some athletes are getting larger short headed biceps, maybe not enough long head, and that's the one that we keep injuring. Is it a factor we should be all looking at?
Yeah, so I suppose for me, this all came from this concept of testing all the athletes, and they're 90% of them are testing really well on my isometric test, my Nordic test, and my IKD test, but still getting re-injuries. So then the question comes, actually, well, is there something beyond just strength testing, which doesn't tell us everything? And I probably have to clarify, because I've kind of done some stuff around, can we get too strong? And obviously it's probably a slightly kind of frivolous headline to come out with, because its question is just really, well, what actually is there more we can add to it, and what underpins strength? Because obviously strength loading, I mean, I'm a rugby physio probably by nature. Strength loading is central to everything, as it also influences healing, as I've just said. But within that, I suppose the question is, just because I can put out good numbers doesn't necessarily tell me how that's been done. The same as I can do a CMJ and you can do a CMJ. We could both hypothetically jump the same thing, but I could be very knee dominant or very fast. You could be very hip dominant, and you could spend some time at the bottom. So the number only tells us so much of how it's created. And I think that probably is somewhere that we can go deeper in terms of our strength testing. And that's where I think like Springbok is probably an incredible tool to use. And probably what I've learned, at least from looking at my own rehabs on this, is tend to see that pattern of load shift. And very frequent what we see is somebody who's got very symmetrical biceps femoris, very symmetrical left v right hamstring, very symmetrical in terms of strength, but actually we see a load shift somewhere within the hamstring group. And I know Michael G. Kumas has published on how some degree of asymmetry is actually normal depending on your sport. And of course, if I think he talks specifically around 400 meters runners having on a given leg, having a more developed medial hamstring. And again, so we take that into account. But it comes back to, okay, well, what story am I trying to unpack here around the recurrent hamstring. And if we have somebody with recurrent proximal long head style injuries, and if we have somebody who has 20% less long head volume and actually got 20% bigger on short head or on the semi 10, well, then it just comes back to, well, okay, how would that influence my exercise selection? If we think that's the adaptation that we want to go after, then are we picking the optimal exercises that we should use here? And I think there's loads of information out there in terms of what those potentially are. But also I think that cueing and conversation is really, really important too. So I have probably 3 or 4 exercises that I'll tend to use in clinic. And I know when I was in Australia, we worked through some of these in person, but effectively the exercises I just use them because they fit my clinic. They fit the small space that I have and the equipment I have. There's probably better exercises out there. These are just what I do. And I'm good at cueing and I'm good at getting people to feel long head. There's a small sub portion of people I can't get it on sometimes, and they tend to be the higher grade of recurrent T-junction, and that just takes either a bit more work, or they might be the ones you start to consider, actually, is this a challenging subtype of injury here that might benefit from another intervention. But yeah, I'll do some prone curl style isometric work where I'm kind of working in from the outside, so basically causing a rotational component from the outside of the heel. I'll tend to do it at a lower MVIC, so probably about 30% intensity when I'm trying to activate the proximal hamstring. I'll put my thumb on the hamstring, say, what are you feeling? Where are you feeling it? Can we get you going there? In posterior tilt as well, with the toes facing the ceiling. I'll do that box to box isometric bridge. Almost always works for everybody. And I'll put a band around their knees, a band around their feet. Usually I'll put a band around both feet and then get them to take one knee to their chest. And that causes almost a rotational component at both the ankle and the knee. That seems to work 8 times out of 10. And I'll do, if appropriate for my BAMIC and optimal healing and my anatomic classification, I'll do a split RDL style variation where I get them either turn the foot in, or I played around putting a band around the ankles again, just trying to create some kind of internal rotation moment that causes the biceps femoris to have to create an external rotation moment. And that, again, I think is your cheat code in trying to activate biceps. I do other variations, like I know, again, to reference Giacomus, he has the bent knee one and the Smith machine. I think that works pretty much every time, unless there's a big lumbar component to the injury. And there's pretty much my starting point. And that, as I say, is a case of I underpin my rehab, but can I get my biceps activation up and running? And then that unlocks all my other exercise selections. So be that my bridges, my slide outs, my length and state eccentric training, my heavy RDLs, etc., etc., etc. No right or wrong approach to it. It's really just, have we got the underpinning foundations to move on to these exercises, or are we using exercises that are just driving potentially an adaptation that we don't want? And that's why, like, I've touched a little bit on the Nordic hamstring exercise, and we look at Mayo's work, and I'd be wary of being misinterpreted on this. What I would just say, when we look at that, some of the primary adaptations that come from that exercise according to that work are large changes in volume of semi-10 and of the short head. And that exercise obviously does lots of really positive things. We look back to Matthew Bourne's work. But if the adaptations that's going to give us are semi-10 and short head, the only question I would go is, if what we're trying to do, if what we think is important is long head, and that's our injury location, then is that necessarily the most appropriate exercise for them? And obviously we won't do any exercise in isolation, but that's just the question that I ask when I raise that point.
Lovely, mate. Now, you have a patient we have to finish up now. You are a patient just arriving in the doors, and I had a few extra questions. We're going to talk a little bit around rate of loading that you sort of speak to in your mechanism, and how do we train for that, and the transfer. Obviously, there's things to delve into there around the short and long head ratio that we can explore further, and a few other bits and pieces. I felt like a nice little fast-paced podcast, but it was really great to have you on. We will delve into those things a little bit further, which obviously announced at the start, our probably super exciting event we have running in Northern Italy at the Australian Institute of Sport. 5 speakers, yourself, obviously you mentioned Giacomus, so mate, that was probably a small snapshot of some of the stuff we'll be able to go into a deeper level there. So really looking forward to you hosting you down there in Italy, mate. And again, we're loving the work you're putting out there. Appreciate you sharing some of your insights and being really open and, sharing the journey of the hamstring discovery process with us along the way.
That's it. Thank you.